To all of you. On behalf of Society of Fetal Medicine, it is my proud privilege to welcome you as we observe the World Rare Disease Day today. What we need to understand that these cases are very complex, and this is where we need to understand that we need intensive help from our clinical geneticists, from the pediatricians, and it's a whole bunch of effort from everybody to give best outcome to the mother and the baby. And on this World Rare Disease Day, it's an important reminder to remember the need for continuous research into prenatal diagnosis, better screening methods, and development of more personalized treatment plans. And today, I think as fetal medicine specialists, we need to pledge that whatever outcome we give to our babies needs to be the best. So I would request Dr. Mohit Shah to kindly introduce Dr. Ratna and take this program forward.
Yeah, good evening, everyone. And as we observe the Rare Disease Day, I feel proud to see the kind of work coming from our country. India is a large country, so by law of averages, by the number of people we have, we do see a lot of abnormal cases. But it takes tremendous dedication, clinical know-how, upgradation of your knowledge to really identify this case as a rare. And not only that, as you will see throughout the webinar today, how the panelists have taken that pain to follow up these cases to a logical end with the help of clinical geneticists, of course. So I welcome Dr. Ratna Puri. She is the Director of Genetics at Gangaram Hospital, a past president of Society of Fetal Medicine. And when it comes to genetics, the buck stops with Dr. Ratna. Whatever she says is the ultimate word for all of us. She is highly respected in her field, and we obviously see her as a one-stop solution for everything in genetics. So she will take us through this, how to navigate this rare path. And I'm really feeling proud of all the people who have contributed to the cases today. Dr. Rima really had a tough time to choose the rarest of rare cases that were presented to her. So it's a very satisfying feeling to see so many people are not only diagnosing them, but they're actually working them up to conclude the diagnosis so that it can further be counseled and the patients are counseled for the next pregnancy as well. So congratulations to all. And I please welcome Dr. Ratnapuri, ma'am. Over to you, ma'am.
Thank you so much, Dr. Mohit. And it's always a pleasure to be here. And I am trying to share my slides. Are my slides seen?
Yes, ma'am.
Yes, ma'am.
Okay. Yes, so this is the time of the year, I think, when there is a lot of nostalgia for me. And so when Rima asked me to speak on this occasion of Rare Disease Day, and we decided that I would want to speak on navigating the path, it brought back memories of what's happened in the last so many years since I've entered this field, from just being a general pediatrician to working within the genetic space. And so this day is all about raising awareness and generating change for more than 300 million people worldwide who live with a rare disease. And not only the patients themselves, but their families and carers, because we see that the entire family is impacted. It's not just them. And 3 to 5% of the population does have a rare disease. 72% of them are genetic. And so we extrapolate this to our population, look at the numbers that we have in our country living with rare diseases at any time. So what is this? Why do we have so much talk about rare diseases? Because they impact a large percentage of our population, even though they, as a common group, are not so rare individually. We would have fewer patients. Our data is limited. Our resources are even more limited. Our training within this field is limited. The talk about rare was hardly there 5 years ago. Therapeutics are there. They are coming in, but they're so expensive, they might as well not be available to our patients. And last but not the least is the huge diagnostic odyssey. And there are many, many papers world over which talk about a 7 to 15 years diagnostic odyssey before they arrive at a diagnosis. And so they stand out like the colored zebra. They are unique, and therefore we need to identify them because of their uniqueness. And that is what I'm really going to be talking in my few minutes today. It's the journey in evaluating rare diseases, the challenging diagnostic odyssey, which has improved with tests, but despite all tests requires persistence. And the answers, and the reason for that is that it doesn't matter what test you use, the answer is really just not straightforward. And finally, what keeps me ticking in this field, which is a rare field, really. I remember when I moved from pediatrics to genetics, my father, who himself was a doctor, asked me, "What are you doing? Do you think that?" I mean, he just didn't understand the reason for the change in the fields that I took, but I have no regrets. And so first talking about the first thing, this is year 2011. Tests were not available. We were very sure that this is genetic because there were 2 boys affected with retinitis pigmentosa. We had to search the world where we could get these, just, you can see, not even a handful number of genes and targeted mutations tested, and look at the cost. And despite spending so much, there was no diagnosis. Until 6 months later, the first panel came up, which looked at 105 genes together. This was the first time I ever heard of something like this. But it was a huge cost, but it gave us the diagnosis. And that was the start so many years ago. The journey hasn't been easy, but the journey has been dotted with families like this, which have actually paved the way forward within this science. Now, these were 2 children born in 2015 and 18 in my hospital, antenatally followed up here. The scans didn't show anything, but as soon as they were born, they went into the nursery. Both of them similarly affected with seizures. There was developmental delay, there was hypotonia, they both had constipation, and they died before their first birthday. On examination, they looked a little different from their parents, and they had extensive skeletal abnormalities that you could see here. And because they were admitted in the NICU, they underwent extensive evaluation. They were diagnosed to have a polyneuropathy. They had a burst suppression pattern on the EEG, and they had an elevated serum alkaline phosphatase, which at that point in time really didn't ring a bell. And the first time, there were so many differential diagnoses for their phenotype. They underwent a whole exome sequencing in 2016, and all these tests were done in-house. There was no answer. In 2018, before we started doing genomes ourselves, there was an opportunity to do genome sequencing outside the country. We did that. The data was analyzed, not only by us, by experts world over, but there was no answer. And for this family who had lost 2 babies, this was actually the end of everything in their life, that we were not able to tell them what happened to their babies and be able to at least close a chapter and open new chapters in their life. And then we sat down again with the phenotype. We looked at the important things: developmental delay, seizures, dysmorphism, hypotonia. These were all common to so many disorders, and we knew that this was not going to give us an answer. And that's when we looked at the serum alkaline phosphatase level in both the children, and they were grossly elevated with a normal vitamin D. And that's what took us into the pathway of these disorders, which are the GPI synthetic disorders that are associated with hyperphosphatasia. So just this one deep phenotyping, the understanding of the pathway of hyperphosphatasia, we looked back into that data of exome and genome, and there was this gene line with the variant. This was a new gene. This was actually the first gene we identified in-house in 2019 without any help from outside. It's because we deeply understood what those children had, and then further went on, collaborated with 9 other patients in the world who had recently been identified to have the PIGB mutation and published this as a new gene. So we order multiple tests, we know that. And we all have the experience that these tests are not straightforward. It requires dedication. And there was this family who was actually a very humble family. The father worked in a showroom. You know, he was the one who showed clothes, and his monthly salary was 8,000. Because all these things become so relevant when you evaluate these patients, because every test, everything that you do requires money unless there is a project happening. And worse still, this happened in March 2020, which was the start of our pandemic, the COVID pandemic. She came in pregnancy. She came with this child who was about 8 years old, severe intellectual disability, microcephaly, significant behavior abnormalities, and a very bad MRI, which showed cortical migration disorder, colpocephaly, and a posterior fossa, which was not normal. And so we thought we'd get the answer because there was so much happening. But the exome, despite all the huge differential diagnosis that we had come up after the clinical examination, came back negative. The level 2 scan was missed because of the COVID pandemic, and suddenly they appeared at 30 weeks of gestation, and we identified that there was microcephaly, some abnormal brain sulcation, ventriculomegaly. We felt that the baby would be affected like the first child. There was an intrauterine fetal demise at 31 weeks. The fetal autopsy was performed, which showed identical findings on the brain autopsy as was present in the MRI of the first child. And so what we did, because at that time we were leading with the undiagnosed diseases program, we did exome sequencing on the fetus, on the affected child and the parents, and so many things came up, but none of them explained the thing fully. And so we said that the quadruple remained inconclusive. I just told the family one thing: you will not have a baby until we give you a diagnosis. And that is the time when these multiple attempts started with multi-genomic testing, learning how to read the genome. It took us 4 years to give this family a diagnosis, but finally we were able to. We did genome sequencing and identified for the first time in our career this huge 700 base pair deletion, which cannot be picked up on an exome. We checked it out in the genome. We checked not only the proband, but also the sibling and the parents. So they were compound heterozygous, one 11 base pair deletion, one 700 base pair deletion, and then one parent was the carrier of one, as you can see here. This was the larger deletion. This was the smaller deletion inherited from the father, the larger deletion inherited from the mother. That was not enough. You have to confirm it by orthogonal methods. So we set up a specific PCR in our lab, which is the gap PCR, to confirm the huge deletion. The small deletion, of course, is easy to pick up. And finally, at the end of 4 years, it was in the 5th year that we were able to give this family a normal child. And so with all this in the background, it's important to understand, I think, and I'd love to share what keeps me ticking. It is these families, it is these patients who actually push you along the way. This is a girl that you see here. She has spinal muscular atrophy type 1-2. I started seeing her at the beginning of my career. She was a young girl. They used to come from Diu, where her parents were, to show herself. There was no treatment. All we could say, please do physiotherapy, move on, live on, because the mind is normal. The body doesn't work. This girl today, she is a young adult. She is wheelchair bound. She requires BiPAP at night. She can barely raise her arms, but she did her graduation from IIT Kanpur on this wheelchair. She works today with Microsoft in Hyderabad, And she traveled the world, as you can see here, as a part of the Microsoft Welcome program for new joinees. So it's these children who motivate you. They do so much. Why can't we do a little? And because they believe that if you dream, you can achieve it. And today I also believe that we can do it. We can make a difference for these families. It's not just one, there are so many of them. And this is actually a fashion photographer, Rick Guati, who came to India, and we got together all our undiagnosed patients, and he brought out the beauty in them. And this whole exercise is called positive exposure, because these are the champions which move us along on this journey. Of course, along with each one of us within the Society of Fetal Medicine, because it has a vision of offering every fetus, tomorrow's child, an optimal outcome. And I think that this webinar itself, talking about rare diseases within this landscape, is testimony to what I believe, that our patients and all of us together are enough to make the difference in our country. And that's all I have to say.
Absolutely mesmerizing, ma'am. You can get goosebumps. Absolutely inspiring. The way you last two slides are absolutely inspiring. Thank you so much for sharing this journey with us. Over to you, Rima.
Yes. So can we just have the trade partner videos, and then we will begin with the uh, all youngsters. Ratna ma'am has been so inspiring. We have a lot of young talent who've come up with some marvelous cases, very well worked up. So our first case is from Dr. Shruti Agarwal from Jaipur. How ultrasound helped her to pick up Kabuki syndrome. Dr. Shruti Agarwal from Jaipur. You can
Am I
start.
audible, ma'am?
Yes, please start.
Yes.
Okay. Good evening, ma'am. Good evening, everyone. I am presenting a rare case of Kabuki syndrome diagnosed antenatally with postnatal follow-up. My slides are not.
Just press on the slide once.
Click on the slide and down arrow after that.
कीपैड का डाउन एरो क्लिक करेंगे तो भी चलेगा, साइड एरो कीपैड का.
They were showing well. Just press on the side arrow. You have, they were running well. Just press on the side arrow. Okay, no problem. If you're having a problem, we can,
Yeah.
yeah.
We'll call you back maybe.
We'll
You
get
can
you
press
back,
it.
Shruti. No
Yeah.
problem. We can
Okay,
take you
ma'am.
at the end. So we have now, if you could just unshare your slide.
Yes, ma'am. Sure.
Yeah. So we have Dr. Bhavya Sareen. She has a very unusual case of congenital lymphedema. Dr. Bhavya is a fetal medicine consultant from Fetal Medical Clinic, Bihar. So she's doing some very good work. Dr. Bhavya Sareen, if you could share your screen. Thank you.
Good evening, ma'am. I have started sharing. Are my slides visible?
Yes, please start.
Okay.
Can you come to Shri?
Yes.
Full screen, please.
Full
Thank
screen,
you.
please.
Okay. So my case report is on a variation in exon 18 of the FLT4 gene causes congenital lymphedema, the first prenatal case report. So this was a Gravida 3 Para 1 Living 0 Abortion 1 patient. Her first pregnancy was unbooked, had an unexplained IUD at around 30 weeks. It was a female child, so they don't have any papers of that. In the second pregnancy, she did not have any first trimester screening and she was referred for an anomaly scan at around 20 weeks. The findings were suggestive of fetal bilateral lower limb edema involving all the three segments. Then, after the report, she did not come back for any counseling. She was lost to follow up after the ultrasound. Maybe she got a termination of pregnancy done at a peripheral center without any fetal testing. And it was again a female child. Then in the third pregnancy, again, no first trimester screening. She came to for anomaly scan at 20 weeks. This time again, the ultrasound findings were exactly the same. In addition to the above findings, this time the fetus also showed abdominal wall edema. That is, the edema of the lower limbs were extending up to the abdominal wall. And there was an additional finding of bilateral SVC, superior vena cavas. And this was a male child. After the abortion, we looked at it. So this time, on inquiring and counseling the patient, she revealed that the husband was also suffering from swelling of one of the lower limbs since birth. Then further evaluation revealed a 2-generation family history of congenital lower limb swelling, sky jump toenails, large caliber veins, and subcutaneous thickening. And they were getting treatment of filariasis at some peripheral centers. So this time, since she had now a very bad obstetric history, so she agreed for a testing. The amniocentesis was done, whole exome sequencing was sent, and then they aborted the baby. We can see at the lower limb edema that is very apparent on this child, but the autopsy was refused by the patient. So the result of the whole exome sequencing was that there was this there was this defect at the exon 18, a missense mutation was found, which was at this time noted as variant of unknown significance because it has not yet been written anywhere in the OMIM software. But after genetic counseling with the geneticist, she told us that this will most probably be an autosomal dominant condition with a 50% risk of recurrence. And the father was advised Sanger testing on the basis of family history. So the geneticist told us that although the variant has been reported as a variant of unknown significance, but it will be reclassified as likely pathogenic based on the phenotypic match and likely familial segregation once it is confirmed. So the reproductive options that were given to the patient were prenatal diagnosis in next pregnancy by CVS at 11 to 13 weeks, IUI pregnancy with donor sperm, or an IVF pregnancy after PGTM. So now I would like to discuss about lymphedema. It can be primary, congenital, or secondary acquired. Congenital lymphedema commonly segregates as an autosomal dominant or a recessive manner, or it can be rarely a part of some syndromic condition. 9 mutated genes have been identified in different isolated or syndromic forms of lymphedema till now. The one that we are describing in our study is hereditary lymphedema 1 or Milroy disease or lymphatic malformation 1. This is a lymphedema with congenital onset of lower limb edema, a prevalence of having a prevalence of 1 in 1,60,000 to 1 in 60,000 people. The onset is usually at birth or in early childhood, but can occur later on also. It can have variable severity, can vary from chronic swelling of body parts to lymphedema involving the complete body. Rarely, a hydropic fetus can also be a fetal presentation. And the cause is hypoplasia of lymphatic vessels, which might be anatomic or a functional defect not yet clearly identified. And the treatment options are only conservative, making it a rare disease. So this is a very detailed study done on congenital lymphedema on 78 families, which were screened for 7 genes that have been reported to be mutated in some families. So there were a lot of mutations discovered mainly in these genes that I have shown in this table. So overall, a mutation was found in around 1/3 of the familial cases that were examined. These numbers were lower when the mode of inheritance was sporadic or unknown. Thus, when evaluating a patient with primary lymphedema, family history is a very important guide to genetic screening. Associated symptoms direct to the most likely genes, like for example, in our case, the aforementioned findings of the first gene FLT4 were matching with our fetus and the father also. So this study shows us that almost 1/3 of the familial primary lymphedemas can be explained by the already found genes. In addition to this study, 2 more genes have been identified after that, which cover almost half of the primary lymphedemas, but still 50% of the primary lymphedemas are still unexplained. So if we describe the genes that have been found in the previous study, we see that all these mutated genes cluster around a central molecular pathway which is involving the VEGFR3 signaling. So the detailed functional link can vary. It can be at the level of the ligand or the receptor. It can be a modification of the receptor activity. It can be at the level of production of the receptor or the regulation of transcription or a downstream target gene. So I would like to say that this finding could help us guide in the discovery of more genes and attain a more precise explanation of the regulation and function of VEGFR3 signaling. Although primary lymphedema exhibits a high locus heterogeneity due to a lot of private mutations, but whole exome sequencing should help us to overcome this heterogeneity and aid in the hunt for missing genes. So, like for example, in this table, we can follow that if we find a primary lymphedema case, look at it whether it is isolated or syndromic, then following the next step, we'll see what are the associated findings. And to reduce the cost, maybe we can first advise testing of these genes, and if negative, then perform a whole exome sequencing. So for the future, I would like to say that someday with all these complete genetic testing, we might arrive at a gene panel someday, which will become a useful strategy to prevent primary and secondary lymphedema. Thank you.
Thank you so much for this crisp information on your case. We will have the discussion at the end of all the presentations. So our next case is by Dr. Aparna Prakash. She's also from Jaipur, and she's giving us a very interesting case of recurrent anomalies in 2 pregnancies with possibility of gonadal mosaicism. Dr. Aparna Prakash from Jaipur.
Am I audible, ma'am?
Yes, please start.
Good evening, everyone. At the outset, I'd like to apologize for my voice. I have a really bad sore throat. So my topic for today is detection of a novel variant of CAT6B mutation in a fetus at 14 weeks in a case of recurrent anomalies in 2 successive pregnancies, a possibility of gonadal mosaicism. So this patient presented to us 2 years back. She was 25 years old with 25 weeks period of gestation. She had a scan showing hemivertebra and VSD. On our ultrasound, we were able to diagnose additional findings of right microtia, bilateral microtia, multiple vertebral anomalies, a Sprengel shoulder deformity, and also multiple fused strips. We went ahead and did a fetal MRI for this patient as well because we wanted to explore the microtia further. On the fetal MRI, we saw that on the right side, there was non-canalization of the external auditory canal and the inner middle ear cavity. Whereas on the left side, the external auditory canal was canalized and the middle ear cavity also was canalized. However, it was small in size. So after the fetal MRI, we were able to give the patient a diagnosis of right sang grade 3 microtia with a very high probability of EAC and tympanic cavity atresia, and left grade 2 microtia with canalized EAC and small but canalized middle ear cavity. Multiple vertebral segmentation anomalies with a Sprengel shoulder deformity. However, the patient refused genetic testing and decided to terminate. We did get an abortus CT done for this patient, and also we had abortus follow-up. And this was the right grade 3 microtia and the left grade 2 microtia. On the CT, we can see that there were presence of these hemivertebrae, multiple butterfly vertebrae, multiple cervical fusion anomalies, the Sprengel shoulder, and the fused strips. So again, the patient presented 1 year later. This time she was at 14 weeks of gestation, and she had an ultrasound with a thickened NT. So because I had already seen the previous fetus, again, I felt that both the ears were small, relatively abnormal looking, and also they were low placed. The NT was thickened. On the fetal echo, I felt that the pulmonary artery was thickened, it was showing aliasing, and the aorta was relatively small in size. Again, this is the 2D image, which I also suspected a small VSD in this case. The PSP of the pulmonary artery was 120 centimeters per second, and bilateral CTEV was also present. And at the time, although I didn't see the significance of this, but the fetus also had a very prominent looking thumb. So in this case, we gave the diagnosis of bilateral CTEV, bilateral pylectasis, pulmonary artery enlargement with possibility of pulmonary valve dysplasia or APVS, bilateral low set ears, and thickened NT. We got the post-natal abortus correlation, and here you can see these are the bilateral CTEV. The toes are prominent. Also, the facies are very abnormal looking with very prominent eyes and an abnormal looking philtrum and nose. The CT showed bilateral CTEV, however, the spine looked normal in this case. So the patient did go ahead with an abortus autopsy, and on the autopsy, they felt that the heart was abnormal in shape, and they felt that this was a case of TOF with a narrow pulmonary artery and a VST. All the other findings were confirmed on the autopsy, and the abortus West showed us a Cat6B positive mutation with a novel variant, and this was classified as likely pathogenic because the ultrasound findings were matching with the genetic syndrome. So the Cat6B gene is associated with two distinct syndromes, the Fay-Barber-Biesecker-Young-Simpson syndrome and the genitopatellar syndrome. 150 cases have been described so far. There is also a registry for Cat6B children, but it's mainly for it's mainly to support families who have affected children. I did get in contact with them regarding the new mutation, but I am yet to hear back. To the best of my knowledge, this is the first reported fetal case from India. And Fay-Barber-Biesecker-Young-Simpson syndrome, it is a variant of Odo syndrome, and it is mainly characterized by distinctive facial appearance with severe blepharophimosis, an immobile mask-like face, a bulbous nasal tip, a small mouth with a thin upper lip, associated skeletal problems including joint laxity, abnormally long thumbs and great toes, and dislocated or hypoplastic patellae. So conclusions in this case were recurrent anomalies in two consecutive fetuses with normal-looking parents. The second fetus was diagnosed with novel variant of Cat6B gene. Is this a possible gonadal mosaicism, or are these differing anomalies? Because it's an autosomal dominant case, it's an autosomal dominant mutation, and our geneticist did give the couple genetic counseling, and our geneticist is very sure that the couple is not suffering and are not carriers. However, they have not undergone carrier testing as yet. So my request is to the esteemed faculty to please weigh in on this situation and what has been their experience with it if they faced a similar situation. Thank you.
Thank you, Dr. Aparna, for that excellent case. We can take on, I think, Mohit sir, we can take on the questions at the end. The discussion can be later. Our next case is by Dr. Nitin Jadhav from Gujarat, case of coronary cameral fistula. It's a very interesting case that he's presenting. Dr. Nitin Jadhav.
Yes, ma'am. Am I audible?
Yes. And start, please.
Is my screen visible?
Yes.
Yes.
Please start.
First of all, I would like to thank SFM for this giving me this wonderful opportunity. On the occasion of World Rare Disease Day, I will be presenting a spectrum of rare disease, rare case, which is actually rare in the literature. But personally, I feel it is actually not rare. Only thing is we are unaware of this entity. I will be presenting 4 cases of coronary artery fistula I have seen in last 4 years. So case 1, she is a 29-year-old lady, gravida 2. She was referred to me for anomaly scan. So this is a cine, 2D cine, where you can see normal appearing heart, all the chambers, inlets, outlets, everything is normal on gray scale. And on a color Doppler, there is a subtle finding. Initially, I thought that is just a kind of a mitral regurgitation. Is it? There is a small amount of jet which is seen arising from the mitral wall. So I thought this is just a kind of a mitral regurgitation. So I just try to document that mitral regurgitation on spectral Doppler. So these 3 are the spectral Doppler images. In spite of giving multiple attempts, I could not document ideal mitral regurgitation waveform on a spectral Doppler just like this. I expected this image, but I got multiple images like this. It was showing mixing of blood flow with PSV reaching up to the 300 centimeter per second. So now I was sure that this is not just a mitral regurgitation, this is something else. So in this scene on the left hand side you can see This is how a normal regurgitation jet at AV wall looks. And in this our case, I just try to focus on the regurgitation jet. And if you see carefully, the regurgitation jet is seen arising from mitral wall, but it is not hitting the posterior wall of the left atrium. Instead, it is going somewhere medially, and if you see carefully, it is entering into the right atrium. You can see the red color jet which is going into the right atrium. So I was sure now that it is not a mitral regurgitation. This can be some kind of a anomalous vessel, or some kind of a shunt, or some kind of a fissure tract. So I went through the literature and I found few articles about coronary cameral fistula. These are few articles. So I got one article where they had mentioned all the they have studied all the cases, analyzed all the cases reported till date. This article is from 2020. So till 2021, total 27 cases has been reported. And if you see here, all the cases have been reported after 19 weeks of gestation. Dr. Charland is the author who she reported first case in 1996. And if you see here in this chart, she is in the top list. She reported almost 6 cases till date. So I reported my case as a coronary artery fistula, and the conclusion from most of the articles is like the prenatally and postnatal encountered coronary artery fistula are associated with the good prognosis in most of the cases, but few may require some kind of intervention. Although half of the prenatally diagnosed coronary artery fistula cases can resolve prenatally, but postnatal surveillance is warranted. This is the conclusion in from most of the articles. So I counselled the patient that it can close spontaneously, and will have a look on follow-up scans. So meanwhile, she went to the pediatric cardiologist for a second opinion, and pediatric cardiologist also confirmed that it is a kind of a coronary cameral fistula. Probably it is extending from left main coronary artery to the right atrium. So patient came back to me at 32 weeks of gestation, and at 32 weeks of gestation, you can see here the fistula is still seen. It is extending from the mitral wall area. It is going into the right atrium. The fistula was still seen, and the rest of the heart is absolutely normal. There was no cardiomegaly, there was no signs of heart drops, and rest everything was normal. So at term, at around 38 weeks of gestation, 2.9 kg normal, healthy baby was delivered. Postnatally, baby was absolutely fine. It was not having any symptoms. So pediatric cardiologist asked to do a fetal echo, not fetal echo, 2D echo at 6 months of age. Then 2D echo was done at around 6 months of age. The fistula was still present. As baby was absolutely fine, no surgical intervention was planned, and the pediatric cardiologist decided to treat that baby conservatively. The baby is right now, the baby is around 2.5 years of age and doing absolutely fine, and we are just waiting for spontaneous closure of the fistula. If it doesn't close spontaneously, we can plan a surgical closure of that fistula, or angiographically coil embolization of that fistula. But right now we are doing nothing. We are just treating it conservatively. So similarly, I have seen few more cases, but at very early stage of gestation. In this another case, this is just 12-week scan. If you see in the scene, apart from inlet, two ventricular inlets, there is one more channel. If you see here, there is a red color one more jet which is seen extending from the apex of the heart and going into the RVOT. This is definitely, unless proved otherwise, this is definitely a coronary artery fistula which is extending from probably a LAD branch from the to the RVOT. The flow within the fistula is usually depending upon the chamber from where it is extending. So it usually extends from high pressure chamber to the low pressure chamber. So in this case, the pressure within the pulmonary artery would be high. That's why the direction of the fistula, or the direction of flow, is from pulmonary artery to the coronary artery. In my previous case, the direction of the fistula was from coronary artery to the right atrium. So this fistula also showed a velocity of more than almost 100 centimeter per second. Actually, this baby had other associated anomalies. There was a situs ambiguous, there was interrupted IVC, there was some kind of a limb anomalies, there were short limbs. So this pregnancy was discontinued. So one more case, I saw this as at NT scan. In this scene, you can see there's a fistulous tract extending from the lateral border of the right ventricle, and it is going into the aorta. And on a spectral Doppler, it was showing a velocity of almost 35 to 40 centimeter per second. And on a transvaginal scan also, the fistula was confirmed. The red colored jet is the fistulous tract which is extending from the lateral border of the right ventricle up to the aorta. So probably it is extending from one of the branch of the right coronary artery to the aorta. It is also showing the flow from aorta to the coronary artery. And I called the patient at anomaly scan for follow-up, and at anomaly scan at 18 weeks of gestation, the fistula was spontaneously closed. I think the reason for the spontaneous closure was the PSV, or the velocity within the fistula. It was low, it was around 35 to 40. That's why it was closed spontaneously. In all the follow-up scans, the fistula was not visible. Healthy baby is delivered at full term. This baby is right now around 6 months of age and absolutely doing fine. So this is one more last case. I have seen this case recently. So on per abdomen scan, there was some kind of a extra vessel I could see just adjacent to the heart, and I was aware of this entity. I just did a transvaginal scan, and on transvaginal scan, I saw a fistulous tract extending from lateral border of the right ventricle, and it was going to the aorta. And I tried to demonstrate on a 3D. This is the fistulous tract extending from ventricle to the aorta. This fistula also showed a low velocity around 30 to 40 centimeter per second. And I did a follow-up scan of this patient, and as expected on follow-up scan, this fistula also spontaneously closed at 20 weeks of scan. This baby is yet to deliver. I offered invasive testing in all the patients, but no one opted for invasive testing. We did dual marker testing in all the patients. All the patients had low risk on a dual marker test. So just few points, theoretical points about coronary cameral fistula. Very few cases have been reported antenatally. Just like in a chart you saw, only 27 cases have been reported. The main differential diagnosis for this fistula are aortoventricular tunnel, pulmonary AVM, aortopulmonary window, and pericardial fluid artifact. Beware of this. Many times pericardial fluid artifact can mimic a fistula. These fistula can involve any coronary artery and any cardiac chamber. Assessment of size of fistula, development of cardiomegaly, diastolic still phenomenon, and hydrops should be assessed on follow-up scan. How to predict a still phenomenon? If there is a reversal of flow in a transverse aortic arch during diastole, that may indicate a coronary still phenomenon. Spontaneous closure of fistula can occur in small size and low velocity fistulas. So, if you saw the article I have shared, not a single case of coronary artery fistula have been reported till date before 19 weeks of gestation, and in last 3 years, I have seen 3 cases at around 12 to 13 weeks of gestation. So, I feel it is definitely not rare. Only thing is we are not aware of this entity. So, just one quote I would like to share: our eyes can see only those things for which our mind is prepared to comprehend. Thank you very much. This was a very small attempt to make you all aware of this rare entity. Thank you very much.
Thank you, Dr. Nitin. I think we will all be on the lookout for a coronary fistula from now onwards. Thank you for
Yes.
those wonderful cases. Next case is by Dr. Dhaval Patel. Dr. Dhaval will be presenting a very rare case of Noonan syndrome. Dr. Dhaval, please. Dr. Dhaval is from Anand, Gujarat. Could we have your on the full screen, please?
Can you hear me, ma'am?
Yeah, you are heard. Can you just take yourself on full screen, please?
Yes, ma'am.
Yeah, thank you.
So today's my case is a Noonan syndrome. So Noonan syndrome, does it a checkmate? So my case is start with a 23-year-old female. Second gravida came for the target scan at 22 weeks. FTS screening was negative. RH positive, non-consanguineous marriage, and no any family history. So my USG finding is pulmonary valve stenosis, hypertrophic cardiomyopathy, pulmonary artery infundibular stenosis, which PSV around 100 to 110 milliperseconds, and polyhydramnios, mild stental pelvectasis, and growth and Doppler appear normal. So we advise the amniocentesis with chromosome microarray 750K with whole exome sequences to rule out the genetic conditions and prenatal genetic counseling. But the patient denied for the genetic investigation and opted for the continuous pregnancy. So this is the 12-week scan. So NT scan is normal. The cardiac screening is appear normal. At 22 weeks target scan, there is a hypertrophic cardiomyopathy. Due to this hypertrophic cardiomyopathy, there is a both outflow is narrow, and pulmonary, this right chamber is right ventricle is quite diminutive size rather than the left ventricle. So this is the cine clip of the four chamber view. This is the color flow of the four chamber view. This is the 22 weeks. Again, this patient came at 24 weeks. Again, this hypertrophic cardiomyopathy, and this is the narrow outflow tracks. This is the 30 weeks. Same finding. We advised amniocentesis, but still patient is denied. This is the images. This aorta is around 80 to 90 milli per second and mid per second, and the pulmonary artery is around 100 to 110. These are the both outflow. This is aorta, and this is aorta, and this is the pulmonary artery. This is mild pelvectasis. So at 32 weeks, patient came in emergency with the pre-prom with the labor pain and delivered by vaginally. Male child 2.3 kg. Baby shifted immediately NICU due to the severe respiratory distress and congenital heart disease. Newborn echocardiography was done, and there is a hypertrophic cardiomyopathy with narrow pulmonary artery. Blood sample taken for the genetic workup, but day 5 babies come in NICU due to the septicemia and respiratory distress syndrome. This is the postnatal echo. It's confirmed that there is a hypertrophic cardiomyopathy and the pulmonary stenosis. So this is the genetic report. Genetic report shown. This is the Noonan syndrome. Apart from the Noonan syndrome, this one more gene mutation is found is IH1 gene mutation. It's called the singleton maternal syndrome. And the carrier screening also positive. Both parents are carrier. So differential diagnosis is, my case is the Turner syndrome is a close differential diagnosis. Apart from the Turner syndrome is a Down syndrome, other rheopathies, genetic disorder like postural syndromes, cardiophysiocutaneous syndrome, Leopard syndrome, and neurofibromatosis type 1, or isolated cardio anomalies like HCM and PS, pulmonary stenosis. So underlying cause, this mechanism of the Noonan syndrome is by this is RAS MAPK signal pathways, which pathways control the cell proliferation and the differentiation, leading to the characteristic feature of the Noonan syndrome. While the singleton maternal syndrome is caused by the mutation in the IFIH1 gene mutation, which is part of the interference signalase pathways, and this leads to the vascular calcification, immune dysregulation, and the systemic damage. So basically, what is Noonan syndrome? Noonan syndrome is a genetic disorder affecting the multiple systems, autosomal dominant inheritance, de novo mutation around 30 to 70% cases. It is the most common genetic disorder after congenital heart disease, cause for the congenital heart disease. The first one is a Down syndrome. Prenatal findings are the cystic hygroma, increased antihydrops, polyhydramnios, pulmonic stenosis, and hypertrophic cardiomyopathy. Postnatal is a short stature characteristic by the craniofacial appearances, pectus deformity, cryptorchidism, wide nipples. Caused by the gene mutation, most common is a PTPN11, SOS1, RAF1, and LSGRT1 etc. It is advanced paternal age is also one of the cause for the Noonan syndrome. So in my case, there is a LZTR1 gene mutation. It is a very rare found in the Noonan syndromes. So the ultrasound findings according to these gene are first trimester are increased cystic hygroma. Second trimester findings are the congenital heart defects, polyhydramnios, renal abnormalities, and hydrophytalis. And the third trimester is the lymphatic abnormalities. Genetic testing is must advised by the amniocentesis or CVS with targeted sequencing can confirm by these LZTR1 mutations or whole exome sequences, but negative testing does not rule out the genetic Noonan syndrome completely. Still 25% of cases with not identified mutations. So these are the most common antenatal features like this Noonan syndrome is affect mainly the lymphatic and the cardiac systems, and sometimes also in very rare cases in the renal system also. So why does Noonan syndrome primarily affect the fetal heart and lymphatic system? Because these RAS MAPK signaling pathways regulate the cell proliferation, differentiations, and migrations. Disruption or mutations in this pathway which result in abnormal valve or myocardial development, which leads to the pulmonary stenosis and which leads to the hypertrophic cardiomyopathy. Mutation leads to the abnormal lymphatic development, which impair the vessel's function and poor drainage, which leads to the cystic hygroma, hydrops, increased anti-lymphedema, and chylothorax. So now a question is why the pulmonary valve is most common associated with the Noonan syndrome? Why not aortic valve? Because Noonan syndrome is caused by the because Noonan syndrome is caused, the pulmonary valve is originally partly from the neural crest derived tissue, which is highly sensitive for the RAS MAPK signaling disruption. So the pulmonary valve is most common associated with the Noonan syndrome rather than the aortic valve. While the aortic valve is embryologically mostly arising from the mesoderm. That's why it's very less amount associated with the Noonan syndrome. These are the Noonan syndrome criteria first trimester and second trimester. If isolated increase NT more than 5.5 mm or increase NT 3.5 mm plus any lymphatic dysplasia, which is the first trimester prompt markers for the Noonan syndrome, while the second trimester are non-immunohydrophytalis plus increased knuckle fold, pleural effusion, pulmonary stenosis, hypertrophic cardiomyopathy, pelvic and polyhydramnios. So these are some reasons for the increase the NT at 11 to 14 week scans. So what is the management of this pregnancy or while this Noonan syndrome? Management of during the pregnancy, regular interval follow-up scan between the 2 to 4 weekly, fetal echocardiography for the cardiac evaluation, Doppler study for the interval growth abnormalities, role of thoracosynthesis and pleuroamniotic shunt after parents' consent or severity of disease, multidisciplinary approach. Delivery planning is mode of delivery by the vaginally, until unless any cesarean delivery for the fetal or maternal indication like severe hydrops or cardiomyopathy. Neonatal care is a tertiary care center, deliver NICU setup, cardiac evaluation after birth, neonatal genetic confirmation if the prenatal testing was not done, and monitor the hypoglycemia, thrombocytopenia, and coagulopathy. The treatment and prognosis of the Noonan syndrome depends on the heart defect, growth delay, bleeding disorder, and the developmental delay throughout the multidisciplinary approach. Prognosis depend on the severity of the cardiac and renal and lymphatic system abnormalities. Early diagnosis and intervention are critical for the optimizing the outcome and improve the quality of life. Mild cases have generally good long-term outcome, but the severe cases, risk of the complication like the heart failure, growth delay, endocrine disorder, these are the chances of in the severe cases. So the regular monitoring and the lifelong surveillance are the essentials. Genetic testing and this targeted mutation analysis also essential. So this case, Noonan syndrome and Singleton-Merten syndrome are distinct genetic disorder with different underlying causes, but they are exhibit some overlapping features, particularly when they evaluating in the fetal anomalies. So take-home message: the Noonan syndrome is a common genetic syndrome, and it is associated with the enlarged antin-cystic hygroma in early scans. It affects the multiple systems. Molecular diagnosis is required. It express of the condition varies greatly before and after the birth. Associated ultrasound anomalies are frequently but aspecific and poorly predictive of the postnatal development. So genetic counseling is very important underlying recurrence risk and the family planning. Prenatal diagnosis is challenging. 7 different genes are involved. Possible normalization of also NT. Frequently late onset of anomalies, sometimes only in postnatal life. Mental development usually good, and do not be too much afraid of the Noonan syndrome. So these are the some facts about the Noonan syndrome. Is 1 into 5 is not non-cause. 85% cases a cardiovascular problem. 25% associated with the language development delay. 75% associated with the inherited cases. There is no current cure for the Noonan syndrome. 50% cases at least one or more eye conditions, and the 60% boys will have a reproductive issue. So these are the mind maps or the protocol which is increase the NT more than 95%. And these are the postnatal infant diagnostic criteria for the Noonan syndrome. So these are the celebrities which is living with or which are the living with the Noonan syndrome, but still they are doing well. Thank you. Thank you, madam.
Thank you, Dr. Dhaval, for taking us through this journey of Noonans. Thank you. Our next speaker is Dr. Aradhana Bhalla from Amritsar. Dr. Aradhana will be presenting a rare case of Bartter syndrome.
Hi, ma'am. Good evening, everyone.
Good
I'm just
evening.
sharing my slide. Yeah. Right. So good evening, everyone. Today I'm going to be presenting a rare case of Bartter syndrome, a case which had a tragic twist, where we'll be unraveling the genetic puzzle in an IVF pregnancy with polyhydramnios. So what if a seemingly normal pregnancy with polyhydramnios carried a hidden genetic clue? Would that have changed the outcome? Well, in order to understand that, let's go through the case. So I had a 27-year-old primigravida who came to me for the first time at 26 weeks. Her only complaint was of respiratory distress. She had an awful medical history where she was not able to conceive because of her endometrial tuberculosis, with 2 failed attempts of IVF with self-gametes. That's when the couple finally gave up and opted for a donor oocyte. And that's what resulted in the current pregnancy. They presented fairly well till 20 weeks. Her anomaly scan was also fine. The only red flag at the time was an increased amniotic fluid. Blood sugar levels were normal. Now, when I saw her at 26 weeks, I saw more than a well-visualized stomach and bladder. The AFI was indeed literally going off the charts on repeated examination, which was suggestive of severe polyhydramnios. And while I got busy taking baby pictures in the ample amount of fluid, I didn't forget my fetal medicine mentoring. And I did counsel the couple for the possibility of an associated genetic abnormality, which could be there, or maybe a TEF, which I could have missed. At the same time, we gave them the option of amnio reduction as a therapeutic option at the time because of her respiratory distress, at the same time to go in for genetic testing of the fluid. But because the cervix was getting shorter, we did counsel the couple about the risk of preterm labor. And before we could indulge in any of this, that's exactly what happened, and there was a turn of events. She ended up having preterm premature rupture of membranes. There was intraplacental, retroplacental, subchorionic bleeds suggestive of placental abruption. She ended up going through an emergency cesarean and delivered a distressed cynosed male fetus of about 800 grams, who, in spite of being on the ventilator, died on day 2. We did, however, convince the couple to send a whole exome sequencing on the baby's peripheral blood sample, and it was indeed suggestive of heterozygous mutations on the SLC12A1 gene, which is known to be associated with Bartter syndrome type 1. Now, there are a total of 5 types of Bartter syndromes. All but type 3 are the ones which present prenatally. Type 1 and type 2 are the ones which are the worst. And because there's a renal tubular pathology, it actually leads to impaired salt reabsorption. And this causes hypokalemia, metabolic alkalosis, and polyuria. And that is eventually what leads to polyhydramnios, the only finding we actually see on the ultrasound. Now, several studies have actually said that these children may have a good survival rate if delivered at term, but the couple have to be well informed about potentially life-threatening condition, which necessitates rapid diagnosis and therapy. And in fact, a study was done on 54 babies in 2023, and they all said that in spite of medical management, quite a few of them ended up having a chronic renal disease, and almost 11% of them ended up requiring a renal transplant. In fact, a strong association with hearing loss was also noted in type 4 Bartter syndrome. Now, it is rare because the entity is reported only in about 1.2 cases in every lakh live births. Moreover, there being an autosomal recessive pattern of inheritance, they have to be explained the need for carrier screening because the risk of recurrence amounts to almost 25%. But here we had a donor gamete dilemma. And unlike natural conception, family history is unknown. So should genetic screening be expanded in ART pregnancies? That's another question which leaves us baffled. The take-home message for our case here is, when you have a case of an isolated, purely polyhydramnios, the counseling is must. You have to counsel them about the maternal risk involved, because with the advancement in gestation, there would be severe polyhydramnios, leading to maternal distress, preterm labor, placental abruption, pretty much everything that happened in our case. We should consider the use of indomethacin amnioreduction, both therapeutic because they eventually end up reducing the polyhydramnios, but they come with their pros and cons. And so close maternal and fetal monitoring is warranted. Now, we are supposed to convince them for genetic testing. Not only for Bartter syndrome, but many other genetic abnormalities have also been associated with just polyhydramnios, like Gitelman syndrome. That is a close variant near Bartter syndrome, but of less severity. For some reason, if they opt out, maybe we can consider biochemical analysis on amniotic fluid. And quite a few studies have reported the use of Bartter index. Now, this is basically the product of total proteins and alpha fetoproteins in the amniotic fluid with a sensitivity of 93%, but this is not diagnostic. So this is one such case which highlights the importance of genetic counseling, preparing the mindset of the couple for possible adverse outcomes. And if you look at the long list of common causes of polyhydramnios, Bartter syndrome may be at the very bottom of the list. But remember, an isolated case of polyhydramnios should not be taken lightly. Thank you.
Thank you, Aradhana, for that crisp presentation. Thank you so much. Our next case is, again, we go back to Barter's. How much fluid is too much? Dr. Chanchal will be taking on a series of Barters. Dr. Chanchal from Delhi. Dr. Chanchal needs no introduction.
Screen visible?
Yeah, your
Is
screen
the
is
screen
visible.
visible?
Yes.
Yeah.
Can we come on full screen,
Yeah.
please?
Yeah. Good evening, everyone.
Thank you.
And after those excellent case presentations, let me add to what Dr. Aradhana has spoken about. One often gets referral for polyhydramnios, but how much fluid is too much fluid? And as Aradhana rightly said, that isolated poly should not be taken lightly. However, one has to have a certain criteria in mind, that when do you get into that odyssey of genetic testing? Because as all of us know, genetic testing once undertaken can be quite a journey, may not give us the answers with the test that we are familiar with. So I start with my first case. So this is a 30-year-old primigravida, a non-consanguineous couple, spontaneous conception with no significant personal, medical, surgical, or family history. The BMI was nearly 32. Her combined first trimester screening was low risk. And in the anomaly scan was unremarkable. Everything looked fine, except that the DVP was 7, which there was a mild poly. So I advised her to do a glucose tolerance test and follow up after 4 weeks. The stomach bubble was well visualized. The bowel looked okay. After 4 weeks, when she did her OGTT at 20 weeks, and that was normal. But when reviewed after 4 weeks, which was around 24 weeks, the deepest vertical pool had increased to 13 centimeter. And you can see in the chart on the right that the AFI was way above the 95th centile. However, at present, the patient was comfortable. She was not in discomfort. The cervical length was 30 millimeter. And there was no obvious structural abnormality. The bowel were not dilated. The target sign was well seen. One does try and look for the pouch sign to make a diagnosis of tracheoesophageal fistula, isolated cleft palate. However, all that looked okay. So I've just put these pictures. This was the anomaly scan at 20 weeks. You can see that the fluid it is mildly increased. However, the bladder looks okay. And the rest of the baby looked okay. Compare with this at the follow-up 4 weeks later, where you can see that the bladder is distended and you can see the massive polyhydramnios there. So one always follows a diagnostic algorithm. There's a checklist that keeps going on. So with polyhydramnios, first is GTT, second is a structural assessment. Look at the fetal heart rate, whether there is any arrhythmia. Look for fetal anemia and isolated cleft palates, which may be difficult to diagnose. So all this was normal in this baby. The review, while we were discussing, should we do an amniocentesis, should we not do, a repeat scan was done after 2 weeks, and now the polyhydramnios was persistent. The bladder was distended, though it was seen to be emptying in between. The kidneys looked absolutely normal. However, the cervical length reduced from 30 mm at 22 weeks, 24 weeks to 15 mm, and then at 26 weeks, it came down to 5 millimeter. So given the very high risk of preterm labor, she was offered amnio drainage as a therapeutic as well as a diagnostic intervention. You can imagine the conversation at this point in time that putting in a needle it itself is a risk factor for going into preterm labor. However, with the cervical length of 5 millimeter, we did not have much choice. So we gave her indomethacin prior to the procedure, both as a tocolysis as well as aimed at reducing the fluid level, gave her antenatal steroids, and amnio drainage was done. 4.5 liters of clear amniotic fluid was drained, and she was reviewed after 1 week. But as is given with these cases, that there is a rapid refilling of the amniotic fluid, and she needed a repeat drainage 2 weeks later. And every time the cervical length used to come down, increase after the drainage, the patient would get some relief. And the QFPCR, the amniotic fluid that was drained, was sent for genetic testing. The initial rapid test came back as normal. The microarray came back as normal. However, the exome, it does take 3 to 4 weeks. And by the time we got the exome, the patient had reached 31 weeks plus. And the exome confirmed the diagnosis of Bartter syndrome associated with the SLC12A1 gene. Now, here, this is just to give you an idea that this is the massive poly along with the distended fetal bladder. And this is the cervical length of 5 millimeter, which after the drainage went back to around 24 millimeter. And that is what gave us time to prolong the pregnancy, because as Aradhana highlighted, any prognosis, the prematurity worsens the neonatal prognosis. So the aim of prenatal diagnosis is to ensure that we have the optimal neonatal management. So antenatal steroids, she went into spontaneous preterm labor a day prior to the planned third drainage. She had an assisted vaginal delivery of a 1.7 kg male baby. The baby cried at birth, had an APGAR of 6-7, required intubation, and then was on CPAP till day 27. The antenatal diagnosis helped in the immediate neonatal management, because the neonatologists and the pediatric nephrologists, they were in the loop right from the beginning, and they knew that this baby will have massive polyuria and will require a large amount of fluid and electrolyte balance. The baby went home after about a month of an ICU stay and was doing well till they did develop ventriculomegaly and hydrocephalus, which was probably secondary to sepsis, but recovered, and had been doing well till 4-5 years of age, when had some brain lesion which required surgery. Currently, the child is not doing well. However, that is not because of the Bartter, but because of the brain lesion that the child has developed. Now, given that Bartter is a genetic condition, although the parents did not have any history, it was a non-consanguineous couple. Both parents were tested and found to be carriers. And they were counseled that there would be a 1 in 4 recurrence in every pregnancy, and a CVS in every pregnancy will be offered. The same couple has had another baby who unfortunately also had Bartter. However, the couple did opt to continue with the pregnancy. And she's required 3 amnio drainages in the second pregnancy also. And this time they've had, the pregnancy was complicated with fetal growth restriction, and she required an elective emergency cesarean because of Doppler abnormalities. And the child, the child was born at around 33 weeks and 4 days and has just been sent home and is doing well. I've not included that case in detail because of paucity of time. because these are two pregnancies in the same couple. The second case, another 32-year-old primi gravida, non-consanguineous couple, spontaneous conception, again, no significant personal medical surgical history, average BMI, first trimester anomaly scan normal. She was referred at 28 weeks, again in view of polyhydramnios. The OGTT was normal. We did a thorough anomaly scan, repeat anomaly scan at 28 weeks. There was no bowel dilatation. The pouch sign was not seen. The stomach bubble was well visualized. Target sign was well seen. The palate looked normal. The MCA-PSV was normal, ruling out fetal anemia. And this you can see where the amniotic fluid is. The DVP is way, way above the 95th centile. Now, again, we counseled regarding both the therapeutic as well as diagnostic role of amnio drainage. And as it is for the first time, the parents, they take some time, especially when the mother is not breathless. And you'll be amazed how women are able to carry on with an AFI of 32. Now, at the review after 2 weeks, again, the cervical length shortened and she opted for an amnio drainage. We drained about 2 liters of amniotic fluid in one sitting. The fetal QF-PCR microarray was normal. The whole exome again reported Bartter in another gene, KCNJ1 gene, which again has an autosomal recessive inheritance. A repeat amnio drainage was done at 32 weeks because of maternal discomfort. A pre-procedure deepest vertical pool of 12 centimeter was reduced to 7 centimeter. This girl did not require any subsequent drainage, and at 36 weeks and 4 days, they decided, rather than going in for another drainage, they decided to go ahead with an elective cesarean. Interestingly, after the diagnosis of Bartter syndrome, the couple approached the medical board and to be allowed termination of pregnancy. However, because it is not a lethal condition, there was a multidisciplinary board meeting, and including the pediatric nephrologist, and they counseled the couple that because it's a treatable condition and this particular gene does not have any neurological involvement, and they were denied this termination of pregnancy. This boy has required 1 week of NICU stay and is currently at home and is a month old and is doing well. The key learning points, the pathophysiology of Bartter has been covered by Dr. Aratna. So the key learning points which I wanted to highlight was that polyhydramnios is common. However, majority will be either idiopathic or they will be due to gestation diabetes mellitus. Highlighting rare cases does not mean that we start looking for Bartter in every case of polyhydramnios from this webinar onwards. However, in cases of severe polyhydramnios, that means when the AFI is more than 30, those are likely to be associated with problems, and common things common. So one must do a thorough check of the fetus, which includes an echo. And looking specifically, we should look for bowel abnormalities, tracheoesophageal fistula, and red. And then at the bottom of the list come rare disorders like Bartter. The indication of amnio drainage in these cases is mostly therapeutic rather than diagnostic. And when one does amnio drainage for therapeutic reasons, one must remember that a microarray will not be able to pick up single gene disorder, and these are the ones who will know whole exome sequencing. The role of amnio drainage is extremely important because it helps in prolonging the gestation, and prematurity worsens the prognosis of this condition. An antenatal diagnosis is not meant for termination of pregnancy. It is meant for helping in planning the delivery at an appropriate center and appropriate neonatal management because of the massive polyuria and electrolyte imbalance these children have at the time of birth. That is what results in acute renal injury and neonatal mortality. So thank you very much.
Thank you, Dr. Chanchal, for taking us through those cases. I think we'll all be very, very skeptical of and look for Bartters. We have our next case by Dr. Prajakta. She is from Hyderabad and she will unravel what BPES stands for, a rare case report. Dr. Prajakta.
My slides are visible, ma'am?
Yes, you're visible. You can come on to full screen, please.
Yeah. Good evening, everyone. At the outset, I would like to thank Society of Fetal Medicine and Rima ma'am for this opportunity. In our day-to-day practice, we come across with various type of facial abnormalities and distinct facial features. So, identifying such features narrows and delineating the things narrow down our differential diagnosis. Here, with we are presenting one of the rare case of and prenatally, it is one of the prenatal detection, one of the first case which got prenatal detection, case of blepharophimosis, ptosis, epicanthus inversus syndrome. Coming to the case, she was Mrs. Yes, out of non-consanguineous marriage, gravida 3, para 2, living 1, death 1. In her first pregnancy, baby male delivered by the LSCS, and as per the history, there was no antenatal events detected, but they revealed that neonatal death happened due to congenital heart disease. No autopsy, no evaluation was done in this case. Then second pregnancy, again prenatal period was uneventful, but postnatally baby got detected with the TJ and large ASD, which got operated on the day 20th, and now baby is doing well. So this is the third pregnancy. She booked with us at 10 weeks, and they were mainly concerned about recurrent heart diseases. They didn't reveal any history as such, medical history or family history, but when I have interrogated to the father, I could notice that some specific and distinct facial feature of the father. So here we can see in the first picture, this is a husband's face, where we can notice there are small eyes with a narrow and small aperture of the horizontal aperture as well as vertical aperture, indicating towards ptosis and blepharophimosis. There was a telecanthus, means distance between two canthi are increased. The curved thick eyebrows and the long philtrum, elevated nares, low set ears. Initially, he denied to reveal history. But after interrogation and insisting, he revealed that multiple family members are affected in the family, including female children also. As you can see in the second and third picture, these are the two children where these are the females which are affected with the similar thing. And till the date, there was no evaluation done for any family members. So I have sent them for the genetic consultation and evaluation. Once geneticists had drawn the family pedigree, we can see here all the brothers and their female children were affected with the similar condition, but we could not understand the cause of recurrent congenital heart disease. First offspring who got operated for the TJ does not have similar features. We have sent the couple exome sequencing, and after analyzing this pedigree, we narrowed down our differential diagnosis as a blepharophimosis, ptosis, epicanthus inversus syndrome, and another differential was Ohodo syndrome, say Barber-Biseker variant. So until we get our results of genetic evaluation, we tried to identify any peculiar feature that we can diagnose on the ultrasound. Here we can see in the at NT scan, NT was normal, FTS was low risk. There was evidence of hypertelorism at 12-week scan as well as at 17-week scan. At 17-week scan, we could notice slight frontonasal flatness as well as small chin, and the fetal heart was structurally normal. Then by the 17 weeks, we got the parental evaluation, and husband was carrier of a pathogenic variant for FOXL2 gene on chromosome number 3q23 for blepharophimosis, ptosis, and epicanthus inversus syndrome, which is autosomal dominant condition, and mother was non-carrier of the similar variant. Here we can see husband was carrier for that mutation. So we offered amniocentesis. Couple was reluctant for this amniocentesis. It was performed at 21 weeks, though we got result at 17 weeks, and sample was sent for a specific variant and KT, and report was released by 24 weeks. By then, legal limit of MTP was crossed, and the fetus was carrying the similar variant which was detected in the father in a heterozygous manner, and positive for blepharophimosis, ptosis, epicanthus inversus syndrome, but this was without premature ovarian failure type, which is a type 2. I will come across through the type in the next few slides. So once we got diagnosis, we tried to identify or diagnose, can we specific peculiar features on the ultrasound. Here we can see there was a mild frontonasal flatness, so small chin was noticed, long philtrum was noticed, there was a hypertelorism, pretal brain was normal, we could image optic chiasma as well as corpus callosum. On 3D examination, we can see here the small horizontal slit of eyelids and nasal bridge to epicanthal distance was increased. So we can compare this picture with the normal eyelids, where the horizontal aperture of the eyelids is quite long compared to in this baby. So we could identify we could correlate phenotypic features with the genotypic features. So after on follow-up, as this was a type 2 BPS in which facial features would be present without any abnormalities like premature ovarian insufficiency, couple opted to continue the pregnancy. Detailed repeat counseling was done, and we have explained the quality of life issues, vision abnormalities, and surgical management in the postnatal period. Delivered by late preterm emergency LSCS due to PPROM and preeclampsia, a baby boy delivered with a 2.7 kg with a good Apgars. And we can see here facial features, postnatal pictures, where facial features are absolutely same like a ultrasound picture as well as familial features. So couple was surprisingly couple was fine with the facial features. Rather, they were happy for there was a no cardiac defect in the baby. Then after delivery, ophthalmic consultation done and the plan for surgery to avoid long-term complications. First, tentative plan would be ptosis correction followed by medial canthoplasty. So a short brief about blepharophimosis ptosis epicanthus inversus syndrome, which is a rare disorder with a prevalence of 1 in 50,000. This is an particularly abnormality in the embryonic development of leads and ovarian follicle, inherited usually in autosomal dominant manner. Components are blepharophimosis means narrowing of the horizontal aperture of the eyelids. Ptosis, as we know, drooping of the upper eyelids, secondary to dysplasia of levator palpebrae superioris. Then epicanthus inversus, there is a peculiar fold of a skin which arises from the lower eyelid and runs towards the upper eyelid. And telecanthus means there is a lateral displacement of two canthi with a normal interpupillary distance. So these are the types of BPS. In type 1, there will be facial feature as well as premature ovarian insufficiency. Type 2 BPS, only facial features will be present. Female with the in a type 1, female with the primary ovarian insufficiency will have a pubertal delay, primary secondary amenorrhea, and complications related to premature ovarian failure. And peculiar thing about this premature ovarian failure, it happens at the age of around 15 years of age, which is very early. And when we screen and we identify any type of BPS, there is a chance that two types can coexist in the various family members. So when we identify one member, we should screen for both the types in other family members. Main complications are common to both types are functional ocular abnormalities like strabismus, and they will have almost 80 to 90% cases refractive errors, particularly hypermetropia. And amblyopia can be seen in 30 to 40% of the cases. They definitely need surgical management at the early age to avoid the complications. They will suffer with the cosmetic and psychological abnormality, and various studies have noted few percentage of hypopituitarism also in future. So how do we diagnose this condition? The diagnosis of BPES is established in a proband with a suggestive finding and a heterozygous pathogenic variant in FOXL2 gene on chromosome 3q23 or its regulatory domain identified by molecular genetic testing. This sequencing analysis identify most of the mutations. Up to 75% of the affected individual have this mutation. In case by the sequencing method, if we are not able to identify this problem, then other methods are there like gene targeted deletion duplication at regulatory domain region, or microarray can be used to detect the deletion duplication at particular 3q23 gene, and very rarely cytogenetic evaluation of balanced translocation at that particular gene. Clinical evaluation is very much important, particularly ophthalmic. Once baby delivers or once adult, whoever patient comes to the clinic, palpebral fissure length should be measured. Evaluation of ptosis, severity or strength of the levator palpebrae muscle assessment is important, and most important is assessment of refractive errors and amblyopia. Endocrine assessment, as I said, in the type 1 BPS, there will be a POI. So that's why we should do endocrine consultation, determine the ovarian function, ultrasound examination for assessment of ovarian reserve. So treatment of this condition is beyond the scope of this short talk. So I will summarize that knowledge of this rare disease is important for prenatal detection, and attempt towards facial feature with the use of 3D is helpful in phenotype and genotype correlation. Multidisciplinary team management is crucial, particularly involving fetal medicine, geneticist, ophthalmologist, oculoplastic surgeon, and endocrinologist. Early detection, early corrective surgery is key key to the success, because it will improve the visual acuity, cosmetic improvement, and elevate the neck strain from the chin up posture. Because of particular appearance of particular structure, to see correctly, these patients usually elevate their chin to get refractive acuity. So if surgery is done, this kind of problems will be solved. And definitely opportunity to screen the other family members, and we can give appropriate guidance in the cases of POI in terms of hormone replacement therapy and cryopreservation of egg for future fertility. And if couple wish for further pregnancy, then option of pre-implantation genetic diagnosis can be given. So this is crux of this crux of this condition is identification of one affected person guides us a chance to screen and manage entire family.
Thank
Thank
you.
you.
Thank you, Prajakta, for that very nice case. We will now go to our last case by Dr. Shruti Agarwal. There was some technical glitch. She will be presenting to us a case of Kabuki syndrome. Dr. Shruti, you can start your case.
Okay, ma'am. Good evening, everyone. I am presenting a rare case of Kabuki syndrome. Ma'am, still slides are not working. Ma'am, can you share my screen?
Dr. Shruti, you can start.
You can start talking. We will move the slides for you.
Okay, fine. Good evening, everyone. I am presenting a rare case of Kabuki syndrome. My patient is primary. Next, ma'am. Please, can you change my screen? Okay. My patient is primary, 28-year-old female, non-consanguineous marriage without any significant drug and family history. Her first trimester screening was low risk, undergone anomaly scan at 20 weeks with following findings. Her biparietal diameter and head circumference was less than 1 percentile. Her CSP was wider. On chest section, corpus callosum was little thicker with irregular borders, but length was normal. At the level of sylvian fissure, there was slight elevation. Patient counseled for genetic test and prognosis. Couple undergone invasive test where FISH and CMA were normal. In the whole exome report, fetus was positive for KMT2D gene for Kabuki syndrome 1, which shows uncertain significance. Patient reviewed at 24 weeks again, where corpus callosum was thick with irregular borders. There was no development of the parieto-occipital fissure. There was slight elevation of the sylvian fissure, but there was no development of the calcarine and cingulate gyri. The development of gyri and sulci appeared lagging, but growth was normal. Patient counseled regarding guarded to poor prognosis and advised to review after 3 weeks and fetal MRI at 26 weeks. Patient reviewed again at 29 weeks where sylvian fissure and parieto-occipital fissure was developed little, but corpus callosum was still thick. This slide shows sonographic developmental milestones of the normal fetal cerebral cortex. This shows sylvian fissure should be present at 18 weeks, parieto-occipital fissure should be present at 20 weeks, calcarine fissure at 22 weeks, and cingulate sulcus at 24 weeks in the normal fetus. This is the normal development of the parieto-occipital sulcus. At 24 weeks, parieto-occipital sulcus should be V-shaped, where width should be more than the height. But in our case, parieto-occipital fissure was not developed. This is the normal development of the sylvian fissure. At 24 weeks, sylvian fissure should be obtuse angled, but there was slight elevation in our case. Patient continued pregnancy, reviewed again at 35 weeks with normal growth, but head was persistently on less than 1%. Patient delivered at 37 weeks, female child, 2.8 kg, cried well, no seizures. Head circumference was 32 centimeter and normal appearance of the head. On day 2 postnatal MRI brain, the corpus callosum was little thickened with shallow gyri and sulci spaces. The MRI finding was confirmed our antenatal USG findings. At 1 month follow-up, head circumference was the same as was on the birth. At the 6th month, there was significantly apparent microcephaly. There was no social smile, no neck holding, bilateral lower limb tone was decreased. Pediatric neurophysician advised to join neurodevelopmental multidisciplinary team. There are few lines regarding Kabuki syndrome. This is a rare genetic condition, occurs approximately 1 in 32 to 86,000 newborns. Definitive diagnosis can be made at any age with a history of infantile hypotonia, developmental delay, and or intellectual disability. And there are two major criteria: a pathogenic variant in KMT2D or KDM6A gene. Second, typical dysmorphic features include long palpebral fissure with eversion of the lateral third of the lower eyelid. Two or more of the following features are arched and broad eyebrows, short columella, prominent ears, and persistent fingertip pads. This is multi-system involvement disease. Intellectual disability may or may not be present. In a very few individuals, seizures, hypotonia, and microcephaly may be seen, as we have seen in our case. KMT2D gene, this is combined with Kabuki syndrome 1, present in 55 to 80% cases of the Kabuki syndrome. This is present on chromosome number 12, inherited in an autosomal dominant pattern. This gene provides instructions for making an enzyme called lysine-specific methyltransferase 2 that modify histones by adding methyl group and regulate the activity of certain genes. In these cases, most likely they have de novo mutation. KDM6A gene is related with Kabuki syndrome 2, that is present in 2 to 6% cases of the Kabuki syndrome. Inherited in an X-linked dominant pattern, making an enzyme called lysine-specific demethylase 6A that helps to remove methyl groups from certain histones and regulate that particular gene. A lack of either of the enzymes produced from these genes disrupts normal histone methylation and impairs proper activation of certain genes, resulting in the abnormalities of development and functional characteristic of Kabuki syndrome. Prognosis: most patients will live into adulthood. Data are lacking on long-term outcomes. The prognosis varies given the heterogeneity of the syndrome. This shows variable expressivity. Some require lifetime multidisciplinary management team. Prevention and management of complications play a key role in improving prognosis. Thank you very much.
Thank you so much, Dr. Shruti. We finally have your presentation. We would now request our experts on the panel, Dr. Sunil Mehta, Dr. Krishna Gopal, and Dr. Aparna Sharma, to give their expert comments, please.
You can unmute, Dr. Aparna.
So we can start with Dr. Aparna, Dr. Krishna, and Dr. Sunil.
Sunil,
Yeah,
sir,
hi.
let's start on what?
Hi, good evening. I was looking for Dr. Sunil, sir, but if he's not there, then maybe, yeah, no.
He's not there.
Not here.
Okay. So a very good evening to all of you. And I think SFM observing a rare these days, like an amazing initiative. And we really started off with a bang with Dr. Ratnapuri ma'am's talk. And it was like seriously inspiring, the passion, the drive to do good. And, being able to reach out to these people and, able to do something. And it is because of people like her that, the government of India has recognized the need. Things are moving, a lot of funds are getting diverted to rare disease. And I think SFM as an association is playing a major role in reaching out to these people and, taking this forward. Again, as far as the presentations are concerned, I mean, I feel that they've been like mind-blowing presentations, each one of them, starting with Dr. Bhavya talking about lymphedema, making a prenatal diagnosis and, connecting it to the father having the edema. And that's really, the clinical and the imaging coming together. Dr. Aparna Prakash talked about gonadal mosaicism and the importance of, and a good imaging, microtia and all of those imaging, which was really brought out an extra features and how to make that connect. Dr. Nitin, no words for your imaging. And now I think every extra vessel that we see, we will start looking for, a fistula somewhere. So I think that's really good. And as Khurana sir suggested, this is something that you must submit to the Journal of Fetal Medicine, opening our minds to a lot of newer things. Dr. Dhaval, great presentation on Noonan syndrome. And I think, the point is the way you said it, like, why this happens in Noonans, and that really reflects a scientific mind, not just reporting something, but why pulmonary is involved in Noonan and all of those things. I think that's how you should think. And we are all inspired by, trying to get to the bottom of the things. And Chanchal and Aradhana, I think the way the Barters are going, it will not remain a rare disease anymore. But yes, I mean, and I think the messages that you deliver, Chanchal, especially you told that not every isolated polyhydramnios need to be, just because we have done this webinar, not every polyhydramnios should be a Barter. So we should have that balanced view. But if it's a severe polyhydramnios, then again, and another very important message that the medical board refused a termination. That again tells us that, if you have a diagnosis, it doesn't mean you terminate the pregnancy. And I will connect that with the last presentation, which was with Dr. Shruti, who described a very good imaging antenatal and postnatal. An antenatal of Kabuki syndrome, the diagnosis was made, and yet the pregnancy continued. So that is a challenge when you don't actually know how the disease is going to present. It could have been mild, it could have been asymptomatic, but unfortunately, the baby had that. So those are the challenges when you have to decide whether you want to go ahead with the pregnancy or MTP. But beautifully presented. And Dr. Prajakta, I think a great genotype phenotype correlation, looking at the parents and the siblings, and and the beautiful description. I think we all learned a lot. We all really had our interest glued on through the entire series. So thank you all very much for inspiring us, and also forward taking forward the SFM's motto of reaching out to everyone and getting knowledge from each part and spreading knowledge to each of us. So thank you very much.
Congratulations, Dr. Mohit and Dr. Rima, for a wonderful webinar and taking this topic forward. Rare disease doesn't seem rare after all these fantastic presentations. What we see, they're of course they are not alone, so they're uncommon, but that doesn't seem rare. What is needed here is the awareness, and from the awareness to the action, because rare genetic diseases are often caused by mutation in a single gene that present significant diagnostic and therapeutic challenges. There are over 7,000 identified conditions, and these disorders impact millions worldwide. Though each affect a very small populations, we have advances in the genetics sequencing, and that has improved early diagnosis. But yet many remains undiagnosed due to the limited awareness and resources. What we need is this kind of webinar where we know about what is Bartter syndrome, we know about what is Kabuki syndrome, because I see what the mind knows. So still in this needs topic, what we are seeing is 150 people listening all these fantastic presentations. Now this is the time for the action where the collaboration is needed between the researchers, clinicians, and the advocacy group, and that is essential for the advancing research and the patient care. So what we needed is this kind of webinar. We also need funding from the government for the newborn screening and the research for the drug development, because many of the families are still suffering, so we can improve the outcome of these affected individuals. What I have learned from these fantastic presentations, that it is not only the single individual, it goes in the family, where we can treat a different subgroups, and we can make them aware for the action. Thank you so much.
Thank you so much to the experts. And now it's the mastermind behind this entire webinar. I would request Dr. Khurana sir to please take on the questions.
Thank you. Thank you very much. Very good evening to everyone. It's been an amazing webinar as always. I am amazed at the quality that we have achieved. And I'm very proud to say that when I look at webinars from all over the world and meetings from all over the world, there is no doubt that our members are way ahead of the rest of the world. It's not just the way we work up our patients and the passion with which we work. It's not just the fact that we work under such compelling conditions, but the fact that we are able to bring out the world's best here without giving up. Most of our cases had a complete workup all the way up to genetics, and nobody would ever expect that from a developing country, and yet it's all sitting there, including treatments. So congratulations to ourselves for having reached this stage. It's been a very, very rapid trajectory to where we've reached, and I think each one of us needs to congratulate ourselves for putting the Society of Fetal Medicine where it is. Thank you very much indeed for that. Moving on to the questions, and of course, with that wonderful remark that rare is no longer so rare. Statistically rare, yes, but the fact is that we're now diagnosing all these conditions. Let's start with the questions from the very beginning. Of course, there were fantastic congratulatory messages that came in initially. And the first question that came in was from Dr. Prasanna Roy to regarding the LZTR1 gene, and Dr. Prasanna Roy wanted to know whether this was recessively inherited. I think that referred to Dhaval Patel's
Yes, sir.
presentation. Yes.
Yes, sir. These LZTR1 mutations is autosomal recessive, although generally LZTR1 has autosomal dominant and autosomal recessive two variant. But this case is autosomal recessive, and parents also find out heterozygous autosomal recessive conditions.
Excellent. Thank you so much for that. And the next question, of course, is again from Prasanna Roy. Do you suggest invasive testing in severe isolated polyhydramnios? Of course, this was to a certain extent already answered, but if we can have the opinions of Aradhana and Dr. Chanchal again, let's see what Dr. Aradhana has to say.
So isolated polyhydramnios, of course, it's something that needs a lot of counseling because there is at the bottom line a risk of genetic abnormality involved to some extent. So we have to counsel them. And if you are anyhow offering amnio reduction when the amniotic fluid is way over 30, why not just test the fluid? But of course, with the costs involved, everyone might not agree. Nothing is an absolute requirement, but definitely counseling is involved here. And if they do agree, we should definitely
Excellent.
go for it.
Thank you. And Dr. Chanchal, would you agree with that? If you could unmute yourself, please.
Yes, sir. I think yes. Massive
Wonderful.
polyhydramnios often requires therapeutic amnio drainage.
And then would we look at 31 or 34 as a cutoff, or should we just use 30?
So I think after 30, I mean, it really hits you in the eye. So
yeah. So I think
putting
we
a
just use
number
30
will not.
because
Yeah.
But you know, for people sitting in little isolated places, we sometimes just need a number to get our confidence.
So I would rather
guess
use a higher
30
cutoff, sir,
would be
than let's make it 35 rather than 30. Because as I said, one shouldn't start looking for Bartter in every poly. And Dr. Rohit has put in a very important point that massively dilated bladder, which we usually
Yes.
see in the recipient in case of a twin transfusion, that is the main clue.
Yes. And then a question from Dr. Ashish Chaudhary on what are the risks of draining too much of amniotic fluid in a single setting? Does this still hold?
So I did reply in the chat box that because
Yes,
we do it manually, but when I was doing a fellowship in Singapore, and many people in our country also, they do say that they are comfortable using a suction machine because it's actually the needle that controls the amount of fluid that is being drained, and it's an 18 gauge needle. So I think there is no upper limit. Once the aim is to bring the deepest vertical pool to 6, 7, 8, depending on where you start from.
Yes.
Yeah.
Entirely. And then it would then depend on how fast it refills and how soon we need to handle that.
Yes.
And
How
of
frequently we
course,
need to
will
drain.
take all our aseptic precautions. Dr. Ratna, would you like to add anything to that?
Sir, we're trying to reduce the stress of the mother, but honestly, it's a very stressful process and it's not as simple as it sounds. putting a needle in there, having to hold it for 2 hours with a machine next to you, and you have to inform the neonatologist, the OT, the obstetrician. Everybody has to be alert that something could go wrong anytime because of a chorioamniotic separation or abruption or distress. It's not very easy, but yeah, we have to be very careful about while we're doing it. It's true.
But Aradhana, I mean, we've never had any, I mean, this is because being a reference center, one does it very frequently.
Yeah.
Usually abruption, I have never encountered because one does it slowly.
True.
It
It's
is
a
a
very slow
theory, I would
procedure.
think. Yeah.
Around
Yeah.
10, 15 ml. I mean, I just connect the IV drip set. You can do a syringing method as well, or you can just leave the tubing, and that drains around 10, 15 ml on a per minute basis. So it's actually a very slow process, yes, which is safer.
No, one does it actively. One uses a 20 ml syringe and one will, because otherwise you'll just spend hours and hours. So 4.5 liter drainage took about half an hour or so. I mean, this is just roughly.
Yeah. Now, there is a question that Dr. Chanchal has answered in the chat box, but if you could repeat for us what if indomethacin caused ductal arch constriction, and do you still recommend it for polyamnios?
Yeah. So yes, that is the Society of Maternal Fetal Medicine has put out a guideline on polyhydramnios. So they've suggested that indomethacin can be used, but should not be used after 32 weeks because that's when the risk is maximum. And even before 32 weeks, if we are putting them in the third trimester, one would call them weekly for monitoring, ultrasound monitoring, to see whether the ductal there is, and then you give it a break and stop it if that starts to happen, because that would be an emergency requiring an immediate delivery.
True. Dr. Aparna had a comment here. Your
Sorry,
hand is
sir.
up.
I think
Yeah.
I rose it. My hand was raised for the previous question regarding the method for amniocentesis.
Yes.
And routinely use a suction. And it is actually the central section which actually comes through the gas pipe, and or else we use a suction machine that is there for our DNC. So either ways, and like what Chanchal is saying, we generally have not taken for more than 30 minutes, and because we routinely do it for TTTS also. As a procedure, amnio reduction is quite okay, and you can probably use a suction machine also. But if I have sometimes, if I don't have it, I do use syringes, and in that case, I use 50 ml syringes so that you at least have the feeling that okay, you're taking out a lot of at the same time. But yes, I mean mostly I think it is safe to do it within half an hour.
Yeah.
So.
And how do you set your suction machines in terms of pressure?
Sir, we generally have a pressure of 100, 200, 300, 400. So generally it is between 100 to 200. So that is what we do. We do not use a very high suction pressure. It is a low suction pressure, and in fact, the central suction has a lesser suction pressure also that we cannot actively control. But again, that works fine for us. So the only thing is that it should not be a very sudden increase and high suction pressure. And once you want to take out the needle, switch off the suction, then take out the needle. The usual precautions when you are doing using a suction. But and like what Chanchal said, not much of a problem due to amniocentesis. Of course, there are other amnio reduction. There are other things which can cause problems, but not
And
not
the
too
needle
many.
is 18 gauge needle. So
18
that
gauge
itself,
needle.
that
Yes. So
itself
that's the
acts
best thing, that you use
control.
the 18 gauge needle, the pink one, so that it is a faster reduction.
Yeah, definitely. And would you use a standard needle or something that you can see better? Like a Chiba, would you prefer a Chiba 18 or a lumbar
No,
puncture?
sir. Actually, we've not needed the Chiba 18 because it is not at a depth. You can just, it's like all in front of you like a football field. So you just put in the needle, very thin abdominal wall, it just goes right in. So we've
That's
not
right.
needed to use the spine. So we use the spinal. We don't generally use, we save the Chibas for the IUTs.
Excellent.
And so the trick is to put it in a lower quadrant, because as the uterus decompresses, if you put it too high, your needle starts getting
Slipping off.
obstructed.
Yeah, exactly. And so then would you put it on the left or the right?
That depends on the
Depends
fetal
on
position ease.
where is the
Entirely.
easiest position? Yeah.
Yes. What I do is I ask the patient before, do you normally sleep on your left or your right? Because that night she might have difficulty, she's going to be in a lot of tension, etc., etc. And then we let them just choose that. There is another question. already answered in the chat box, but if we could repeat that for us, the while we are waiting for the rest of the results in Bartter's. Dr. Chanchal? A question about the electrolyte, the amniotic fluid electrolyte evaluation. So if you could unmute, please. Are you able to unmute, Dr. Chanchal?
Sorry, my cursor got unstuck.
Yeah.
So electrolytes, yes, we do send because it is the amniotic fluid. We do check electrolytes. It helps us in having a provisional diagnosis. The absolute diagnosis is the exome, but a low sodium, low potassium that helps in getting a provisional diagnosis. We do send it.
And would you have a chart that you would refer to then to see what you read off as a?
So usually the pathologist, they say that because it is serum, it is equivalent to serum. So they use the same reference ranges. They in fact also do the osmolality. We use the same reference ranges. It's actually very, very low.
Excellent. Yes. And this, I was just looking for whether we have any other questions, and we don't seem to have those. And I just realized that out of the list of invasive procedures that we do have, guidelines for by the Society of Fetal Medicine published in our journal Fetal Medicine, we don't have any for amniotic reduction.
Dr.
And may I
Dhaval has
request Chanchal and Aradhana to get together? Sorry, no, I mentioned that, we, in our general collection of guidelines for invasive procedures, we don't have a guideline for amnio reduction. So if you, Dr. Chanchal, along with Aradhana and Dr. Aparna, perhaps get together and write out guidelines for us, we publish them in our next issue. Because that's one of the few procedures we don't have guidelines for.
True. And so Dr. Dhaval has answered in the chat box that Bartter affecting renal function leading to imbalances in electrolytes. Sodium, high sodium and chloride concentration. And
that's right. No, I was wondering which chart we use, whether there is a specific chart that we use.
And we'll have to look for it.
Yes, because some of us in smaller towns have so much difficulty because pathologists can give us a figure, but they can't really give us, whether it's high or abnormal or low. And so then perhaps we could refer to that and we could include that in our guideline as well. Wonderful. Excellent. That brings us to the end of all these questions. And like I said, I'm absolutely amazed, completely amazed at the quality of our presentations today, and I congratulate everyone for putting this together. A very special thanks for Colonel Rima Bhatt, our National Secretary, for having put together this program, and for inviting Dr. Ratna Puri for that very inspiring talk she gave us at the beginning, and also for actually mentoring each one of our speakers and making sure that all of this goes smooth. A lot of our speakers are first-time speakers, and it didn't seem like first-time speakers. Thank you, Dr. Rima Bhatt, for guiding them through this. And to each one of us who has been a part of this webinar, a very, very special thanks. And of course, to our team of experts, as well as to Dr. Mohit Shah for always inspiring us at the beginning of our program and sitting through it with us. Thank you for being here. And Conferences International for always being there for our quality of our webinars. And for Vishal Mittal, who's always our behind-the-scenes hero for making sure that everything goes smoothly. He's actually driving back at the moment from Rishikesh to try after tying up our conference there, and he's managed to do all this from there. So thanks, Vishal, for doing this for us. And with that, thank you very much and good night.
Good night, sir.
Thank you and good night. Thank you. Thank you and good night.